Good evening. Welcome to the MyCP webinar for November 19th. My name is Paul Gross. I am your host for this evening. I'm really excited to talk to you about this project. It's been about 2 years in the making, maybe longer, to create an HIE registry, and we'll be doing some definitions and whatnot. So we've got two great speakers, Dr. Danielle Barber and Betsy. Betsy, is it Pilon? I always said it wrong. Betsy Pilon.
Yeah, you got it.
So I got to get better with that. Okay, so our agenda is I'm going to do my usual introduction to the CP Research Network. So for those of you that have attended before, there'll only be a little bit of new information here. And then I'm going to turn it over to Dr. Barber and Betsy to talk about the HIE registry. And then we'll open it up for questions. Okay. So I like to start with telling people about why the CP Research Network exists. And so in 2014, late 2014, there was a National Institutes of Health meeting entitled The State of the Science and Treatment in CP. And that meeting did something better than many other NIH meetings that I've been to, where at the end, the organizers stood up and they talked about the things that they heard were the most pressing things, and they assigned people to task forces to move those forward. And so a lot came out of that meeting. So one was the need to establish a national registry so that we could track people with CP and we could accelerate research. Oh, my slides just went away. Let me see what happened there. The second was that we needed more comparative effectiveness research. So this is where you compare interventions. This picture is from Dr. Iona Novak's Stoplights paper. It's a great paper to read if you have CP or a kid with CP. The green circles are things that there is good evidence that they work. The yellow circles are things that are either above the line or below the line, not as great evidence, but probably not harmful, probably worth doing. But if you notice, like, there are a ton of motor interventions. There are a ton of tone interventions. And so comparing them is absolutely critical to sort of chart a course for people. The other thing is most of the research at the time was being done to study kids. And, you know, if the estimates in the United States are there are 1 million people with CP, if that's the case, there are only 200,000 kids and 800,000 adults. So adults were truly underserved by the research efforts back in 2014. There was a distinct need to develop a research agenda for basic science and translational research. So research that happens in the lab and then figuring out how to apply that to human subjects, to living people. And a need to bring more young investigators to the field. This meeting had a lot of kind of gray hair sitting around the table, and everybody was looking around saying, we need a new young crew to sort of take over and move the field forward. And there was a real need. There were a lot of parents and people with CP at that meeting, and there was a real need to create a closer set of connections between patients, families, and investigators. And so I was one of the people assigned a task force coming out of that to lead the effort with Deb Gabler at Shirley Ryan Ability Lab to define a national registry. But very quickly, CPRN was born out of that and ended up taking on all of those objectives. And so we have a mission to optimize the lifelong health and wellness of people with CP and their families through high quality research, through education and community programs. And so this is a shot of about 45 of us assembled in Chicago in mid 2017 doing a patient-centered research agenda, meaning we involve the community. So this is about half community members and half clinician researchers getting together to set an agenda, which we published in 2018. Then we went on to build a network of people. So in the upper left, we gather twice a month, and then in person, we gather face-to-face twice a year to move forward research and quality efforts. We have a number of educational tools, and then we have a health and well-being program. And we're very focused on efforts like this to engage the community in research. And we're going to be doing a lot more with engaging the community in research. So our vision is that by engaging the whole community, both the people that treat and care for people, as well as community members, engaging you all, along with a very large number of health systems, we can create a learning health network. And that's basically hospital systems that come together that use the data from the care of people to improve people's outcomes, to improve their quality of life. And we focus that on what we've been told through our patient-centered research agendas matters most to you: participation, quality of life. And then we share those experiences and we measure the healthcare process. So by using this data capture of this learning health network, we're able to measure our impact. So just some key milestones since we were founded in 2015. In the year following that meeting, we focused first on education, and we launched the CP Toolkit, from diagnosis to understanding, and that's been served up to more than 6,000 people. We released the well-being guide, respite kind of care guide for parents and caregivers, translated the toolkit, and then we launched MyCP, which is an online portal to get personalized information and access our research platform. And then we do monthly webinars just like this. On the research front, we did that first thing that we were founded to do, which is we launched a registry or a database of people with CP. That was launched in March of 2016. It now has, I was actually just looking at it today, and it actually has over 13,000 people in it. So I got to update that number. And we have a community registry that, instead of capturing information about people when they're in a hospital setting, captures information when they're out and about in the community. What are their school experiences like? What are their work experiences like? We did our patient-centered research agenda that I showed you the picture from, and that we use that to guide our work. And then we went on to get some significant funding in genetics and made a partnership with the largest private funder of CP research in the US, CP Alliance Research Foundation. We also do quality improvement, which is just another way to improve outcomes. It's actually much faster than research, but it's not about generating evidence and then implementing it. It's more of a sort of a checklist medicine way of improving outcomes. So we have a number of these efforts across the network. And then we're very academically focused. We want our work to change the world. So we've published over 16 publications. We've had over 45 academic presentations, and we have numerous manuscripts that are either out with editors or in development right now. So we're going to continue to publish broadly off of our work. And right now that we have this big registry, we're starting to do a lot of secondary analyses. So take the registry data that we have and what can we learn from it, and generate those, and then use the data from the registries so that our investigators can go off and get funded for bigger research projects. And then on the wellness front, we've partnered with the National Center for Health, Physical Activity, and Disability to offer the mentor program to adults with CP, and we're working, it's available to anybody with a disability, a physical disability, and then we're working to develop a pediatric program. So a little bit about what a registry is, because that's going to be a big topic tonight. It's has data points about someone that has some condition or something that you want to study or improve care for. So in cerebral palsy, one of the key measurements is how people move around in the community. We have a 5-level scale called the Gross Motor Function Classification System. 1 through 3, get around independently, but maybe using assistive devices. 4 and 5, get around using a wheelchair. And so you see the distribution of our 10,000 people back in May, that we've pretty evenly distributed across the different GMFCS levels. And then you see on the right a graph of the percentage of people we have by age, and we have about 25% of our people are adults but a lot of our centers are pediatric hospitals, so we've got a lot of kids in our registry, 75% of the people. Our community registry looks quite different. And so as of May, it had about 2,800 people in it. And you look at the distribution of GMFCS, and it's quite different because it reflects a bias of who's out there on the internet looking to contribute their information to advance research. And you look at the age and you see it's like predominantly adults that are out there advocating for themselves and for more research. So we are 35 centers in our network. The green pins represent sites that are actively collecting data into the registry. If they've got a green circle around them, they're a lifespan center, so they're collecting information on both kids and adults. The yellow pins are sites that are onboarding. with our technology. The red pin is a site that for a long time has been working on just getting the agreements done. And then the blue pins are all the sites that have raised their hand and said, we want to join the network. We just have to figure out, how we're going to do it and who's involved. And so it takes a few months for people to sort of figure that out and get onboarded. So our strategy is to create a research ecosystem that lets 1,000 flowers bloom. We're not trying to, we don't have money to invest in research. We have money that allows us to have infrastructure like the registry to make it so that investigators can then use that data to go off and get public funding from the likes of the National Institutes of Health or the Patient-Centered Outcomes Research Institute. So I want to describe a bit about this. So we're very focused on being patient-centered as opposed to investigator-initiated. It's like every idea has to be one that the community cares about. We build this infrastructure, we build the registries, we have the way we bring all the sites together in the network. We have a data coordinating center that stores the registries and works with our investigators. We try to balance between generating evidence, which is research, and just improving care, which is that quality improvement. And then we use the registry to monitor how we're doing. How are the outcomes? Are we improving them? So to let these 1,000 flowers bloom, we've developed a sort of whole pipeline of how can you generate a concept, get that concept approved, get it funded, get it implemented. And then when you've got results, how do you write that up and publish it and then use those results? So I'm going to run an animation that is going to show you how this work started in 2015 and how it's progressed through till today. And there's going to be these like pale yellow bubbles or white bubbles are child-focused studies, pink are adult-focused, and gray are lifespan. So it's going to take about 10 seconds. And there we go for 2024. And that's not actually all that we're doing. We can't actually fit all that we're doing in a font that's readable, but it's a lot of the activity progressing through. So you get a sense of that. So why did we want to move our registry into the NICU? Well, that's because at the time that the CP Research Network was founded, the state of the art was the age of diagnosis for CP was around age 2. Subsequently, an algorithm was developed to detect CP during the NICU stay or the follow-up to the NICU stay and be able to diagnose CP as early as 4 to 6 months and then be able to intervene earlier and improve outcomes. And so that necessitated us moving into collecting data through the NICU so that we could support early intervention research and also hypoxic ischemic encephalopathy research. So there are really 3 elements of this. That element of supporting early detection, and then some of those kids that are considered at risk and get put on that early detection care pathway end up not having CP. And so it's important to sort out what their follow-up looks like. And researchers are interested in studying the results of this brain injury, regardless of whether or not it results in CP. So if you look at what we've been doing over the past 9 years, we've been very focused on developing a registry with all these sites and providing a set of services that really support the generation of a lot of research, and we have a number of services that we offer. And now what we're doing is extending those services and that research infrastructure in partnership with Hope for HIE and the Newborn Brain Society. And this is really going to expand the amount of research that can be done into HIE. So ultimately, our value proposition for the CP Research Network is we provide this platform for continuous research and improvement. And it allows us to study children through into adulthood. So it is longitudinal much greater than the length of studies that are done under NIH funding. It implements a learning health network, so the data from CARE is used to improve care, and now we are looking to expand that into the study of HIE. So I'm very excited to be able to introduce our speakers, Dr. Danielle Barber and Betsy Pilon, who I've been working with for quite some time.
So thanks for the introduction. And Betsy and I are going to tag team a little here. And we thought we would start by just defining HIE. So actually, first, I just want to say, Paul, that was an amazing introduction, and I'm impressed every time. I think those slides, particularly that animation, shows the power of CPRN and the progress that this community has made. And we are so excited to join the community and to build on the foundation, the incredible foundation that CPRN has built. So just making sure, the folks listening to this webinar, the regulars know very well what CP is, but maybe not everyone knows what HIE is. And so being asked to speak today about an HIE registry, wanted to make sure we're all on the same playing field and start by defining HIE. So it stands for hypoxic ischemic encephalopathy. And the hypoxic means not enough oxygen. The ischemic means not enough blood flow. And encephalopathy is a really general word that just means something is going on, something is going wrong in the brain. Sometimes HIE can be confused, or terminology can get confusing between HIE and neonatal encephalopathy. And here, Betsy made this slide and put a beautiful umbrella here, which neonatal encephalopathy is more like an umbrella term, or a bigger basket, a bigger bucket. It can include HIE, and it can also include a bunch of other things that are ways that the brain can get hurt and can cause changes in the way the brain functions. And so sometimes some studies will talk about neonatal encephalopathy, and we talk specifically about a subset of that, which is HIE. It's important to know that HIE is actually pretty common. There's about 1.4 million kids per year around the world who have HIE, and it is the second leading cause of neonatal death and disability around the world. So it's not a small community. And currently, there is only one approved treatment in the US for HIE, and that is cooling, or therapeutic hypothermia. So here you can see a picture of a baby in a cooling blanket being kept cool for 3 days. It is a treatment, but it is not a cure, and we have a long way to go with improving treatments for HIE. We know that not all babies qualify for cooling. It doesn't help preemies. It doesn't help babies born in low and middle income countries. And so we have a long way to go with needing more research. We know that HIE can have many long-term impacts. And maybe you can see over here on the left, one of them is cerebral palsy. And there are many others too, including seizures or epilepsy, intellectual, cognitive problems, attention, behavior, vision. Many different things can happen as a consequence of having HIE earlier in life. And so that's an important thing to know, because there's an overlap. There's a connection between cerebral palsy and HIE. So HIE is this diagnosis that may happen usually in the NICU or early in life, whereas cerebral palsy may happen when a child is a few months or even years old. but there's some overlap. So we think about between 5 and 20% of kids with HIE will develop cerebral palsy, and maybe 5 or 6% of people with CP had HIE as the cause or the reason for their cerebral palsy. Although things are changing, and we know that CP can be multifactorial for many people, a lot of contributing factors, and it may not be just one piece alone. So this this connection between CP and HIE is part of what energized us to work together, Paul and Betsy, to really start working together. And you know, we share a lot of the same interests and motivations, and a lot of the same community. So there should be a synergy here. What are some of the questions that we have in the HIE community? Well, we know that after HIE, there can be a wide variety of outcomes. And even when we pay attention very carefully to exactly what happened in the NICU, we are not very good at predicting what that will mean for that child later in life. There's a wide spectrum, and we're trying to get better at paying attention to the details and seeing if we can figure out what are the factors that may help us give better predictions. Because of course, when this happens early in life, that's the first questions parents ask in the NICU is, what does this mean for my child's future, right? There are many other factors that are really important. Oh, sorry, my office lights turn off if I stay still too long. But one that we just talked about last week at the Child Neurology Society annual meeting, and I think I saw Alexa Craig here on the call. Alexa, Dr. Craig led a group to start discussing. You know, we don't have standard follow-up protocols for kids after HIE. What kind of doctors or therapists or teams do these kids need to be seeing, and at what cadence? What are the things that these families need to look out for? There's a lack of long-term data. Much of the data collection in HIE about HIE has been done by neonatologists and neonatology teams. And, you know, because of grant structure, funding, and other reasons for the way things are done in research, a lot of the data that we have on what happens to kids after HIE, really the most data we have goes up to about 2 years old. We have some more data about what happens to kids till about 5 years old, but then it really falls off, and there's so many questions. We know from the HIE community that many anecdotal stories of kids who develop epilepsy later in life, you know, when they're teenage years, for example. But we don't have numbers on this or factors that might contribute to that. And so we really need to build the research community in order to get answers to some of these questions. So we've listed here several of the kind of questions that we're curious about from the HIE perspective. I think so in order to start addressing these questions, we wanted to start building an HIE registry to be able to keep better track of this information and start to answer some of these questions. And we are so lucky to partner with CPRN, who has already, you know, is ahead of the game and has done so much of the hard work of building this wonderful infrastructure. And now we get to partner and kind of piggyback off of the hard work that CPRN has already done and built, and kind of grow and expand this to include HIE. So what I'm showing here are two sides. On the left side of the screen, you can see the heading says clinically entered data. So what does that mean? That means when when a baby's in the hospital in the NICU, so that's the neonatal piece, or as a child keeps following up later, whether it's in a neonatal follow-up clinic or when they come visit their neurologist or their rehab medicine team, uh, those clinical encounters can be documented. And just like CPRN has their clinical registry, we would expand that to make sure that the data elements, the important information about that clinical care is entered, and we can keep track of the factors that are important from the perspective of the clinical team. Now on the right side of the screen, you can see the heading is caregiver reported data. And this was a really important piece for us because we know I'm sure I'm preaching to the choir for the audience that's here, but you know, it's been growing attention in the neonatology world that sometimes the things that doctors pay attention to are not the things that are the most important to individuals or their families and caregivers. And so this piece of having caregiver reported data was super important to us because we want to know what are the things that are most impactful on life, on quality of life? What are the things that make life great? And what are the things that make life hard for people after HIE? And also, some of those are things that are hard for clinicians or researchers to measure. And so we really need the community to contribute that information and to tell us what are these important factors. And I'll draw your attention to the middle of the screen. This is a really important part, this chain link in the middle. So we don't want to do this research in two silos. We don't want to do them separately. We want to be able to connect the dots and say, okay, here is one person, here are the pieces of information that their clinical team thought was important, thought that encompasses the story of what happened to them, both early in life around the HIE, around the brain injury, and as they progress through the medical system. And we want to connect the dots with what that person or their family thinks is really important, and how they're doing, and be able to compare the data on both sides. So this is really the structure of what we built with the partnerships between Hope for HIE, CPRN, and the Newborn Brain Society. Betsy's gonna speak in a moment to tell you a bit more about Hope for HIE, so that hopefully you can hear why Hope for HIE is really the perfect partner to CPRN for doing this work. I'm gonna I think this slide encompasses most of what I wanted to say, but for those folks who are really into the nitty-gritty, I'll give you a little bit more detail, and I'll go through this a little bit quickly because maybe you don't need all of the details in this part, but I'm happy to, in the question and answer part, if folks have more questions, I'm happy to get into these details further. So specifically, we applied for a grant from the Pediatric Epilepsy Research Foundation, which is an organization that funds research in child neurology, not just in epilepsy. And we were awarded a pilot grant from them. And this is kind of the structure of the grant that was awarded. So in aim 1 of the grant, the first part of the grant, it is building that clinical registry, collecting data that from the neonatal course or from neurology follow-up clinic, and making sure that we're starting for this pilot grant with just a proof of concept, coming up with several data elements, not too many, that we know are important, and making sure that we can show that they can get into the clinical registry. People who have been really important in pushing this work forward. One person is Eric Peoples. He is a neonatologist at the University of Nebraska. He has been leading a project through the Newborn Brain Society to try and figure out, what are the data elements? What are those pieces of information that we keep track of in the NICU course that are important to pay attention to? So Dr. Peoples has been leading a group of international both neurologists and neonatologists who are interested in HIE, collected a whole bunch of registries from around the world where each of those was at a single site or one kind of smaller registry, and trying to line them up and say, hey, across all these smaller registries, what are the data points? What are the data elements that we think are important? And it turns out that there's not very much agreement among those different registries. So it has been an enormous amount of work that Dr. Peoples has led to try to herd the cats and decide, making sure that we can compare apples to apples and collect the right information in the right way for when we grow this piece of the registry. The other really important person on this slide is Joyce Trost, and I think hopefully a bunch of you folks in the CPRN community know Joyce. She's been critical for helping us think about these data elements, think about which of these data elements already exist in the CPRN infrastructure, which may need to be tweaked, how we may need to add or contribute to CPRN in order to grow this piece, and all of the mechanics of figuring out how to do this. So couldn't do it without Joyce for sure. All right, so that first part was aim 1 is building that clinical registry piece. Aim 2 is the other half of the pie, like I showed on the slide before, the community registry. And I know Paul mentioned at the beginning how many folks are in the CPRN community registry. And it's many fewer than are in the clinical registry. So it's a really important piece as well. And certainly, if you are interested in joining the MyCP, the community registry from CPRN, I certainly encourage it. And we are going to build a parallel structure called MyHIE, which will be the HIE community registry, where that will be the entry point for collecting that data, the information from individuals with HIE and or their caregivers or family parents to be able to keep track of lived experiences. And then aim 3 of the grant is that linking piece, being able to connect the dots and have the same person on both sides and making sure that their data is shared across those two pieces. So that's the whole structure of the grant. And, I just want to bring again the idea of this synergy. The folks on this call know a lot about CPRN already. And I wanted to introduce Hope for HIE as the right partner for CPRN for building this infrastructure. And so now I'm going to tag to Betsy. And Betsy, I'm happy to move the slides if you want to tell everyone a little bit more about Hope for HIE.
Absolutely. Thanks, Danielle. And I'll just give you a next slide cue. Thank you, Paul, for having us and for everyone joining. This is definitely a labor of love for all of us that have been working on this for so many months now. And I'm thrilled to share with you a little bit about Hope for HIE. You can go to the next slide. Oop, there we go. So, just like CPRN and other organizations, you start because there is an unmet need. So for Hope for HIE, there was a lack of representation. There was no organized advocacy for HIE prior to us starting. And we started as a support group in 2010 and started the foundation now, celebrating our 10-year anniversary. And there's significant disparities in care, varying resources. We do connect a global community of over 10,000 families now. There are about 200 to 300 when I joined in 2012 after my son Max was born. And those, the programming, the care, all vary by country, by state, by location where you are many times, which is very frustrating, for the community. Danielle spoke about the lack of longitudinal outcomes, the gaps that exist between the specialties that care for these children who grow up to adults, the bias that does exclude our families often in the NICU with quality improvement initiatives and equity of focus. It's very dominated by prematurity with a lack of representation. For families like ours, there's just the basics of naming the diagnosis, communicating the diagnosis. A consensus of what that is varies widely in the medical community. And so we strongly believe that families should have access to first language accessible educational information about this. There was nothing when my son was born in 2012. And kids grow up, so we need to center that lived experience. What I love about CPRN is there are so many active adults because as families helped light the way for me personally in my early journey, we look to people with the lived experiences to help us parent, help us make decisions when there's many different things happening, and look to how we can all work together in this ecosystem. Next, please. So this is kind of where our community is located. Danielle mentioned the sheer volume of HIE, and primarily HIE is a low and middle income country issue. So the lower resourced areas in the world have the highest burden, and a lot of that is directly tied to poor prenatal care and poor birth care, and obviously it has a very high mortality and morbidity rate. Our team, 4 years ago, actually, I started as the executive director, and I was the lone staff member. And today we have actually a couple staff members on the call, which I love to see. Program manager, social worker, child life specialist, clinical research program manager that just joined, and a program coordinator with us. We have a wonderful board of directors Danielle sits on as well. Wonderful medical advisory board that Alexa Craig and Danielle Barber sit on in this call. We have, partners of hope that all of this ecosystem, has helped us scale. We have a big, emphasis, our 5 pillars, I guess. We used to just have 3 of awareness, education, and support, but really it's awareness, advocacy, education, research, and support in reality of where we are now. So it's exciting to have, you'll see that reflected in our staff and in our programming and services as an organization. Next slide, please. So with our programs and services, we really try to do what we can, where we can, how we can. I think like any other nonprofit organization out there, with the limited resources that we all do have, we try to make, again, our programs and services across all ages and outcomes. We have specific resources for bereavement and loss, sibling support, demographic support. We make them worldwide and as accessible as we can. I mentioned the professional resourcing with staff and partnerships, and then we have a significant peer support program as well. Next slide, please. And so community involvement and research, we've really been accelerating this the past 2 to 3 years, but it really started in 2019, working with the Neonatal Seizure Registry project, finding out in 2019 that HIE is the largest cause of neonatal seizures. So that was a fun one as well, because there's just so much lack of information that was, I think, accessible to our families to even learn that. But we partner in many different ways with researchers now. And we have built a model to try to, close a lot of the gaps that exist with neonatal clinical trials, which is where a lot of the research takes place for our families. And as Danielle mentioned, we have one therapeutic intervention that is approved and safe and moderately effective, but not necessarily accessible again worldwide. And so we are in desperate need of more. And, you know, obviously, ultimately, you know, looking at prevention, but there are many causes to HIE. So there's a lot of complexity, but that's never something that I think stops me or others that are dedicated to this work. We like the problem solving. It's a fun thing to take complex topics and try to move things forward. And so, you know, when we look at this from our lens as patient and family centered research and care, and especially looking at, you know, moving research forward like we're talking about today, finding mission-minded people like CPRN, like researchers, some that are on this call, others that are out there, like other organizations that are the actual, you know, industry partners that are advancing things through the pipeline, and looking at how we all interact in this ecosystem. Because we know that when you have that mission alignment, then you can really do the best to engage participants. And CPRN has done such a wonderful job. And we don't want to recreate the wheel. So I think that's a big focus for all of us. And then looking at obviously the most complete data, because that continues to be an issue for us and a lot of places out there. In the landscape of advocacy and research, again, lots of different logos, lots of different groups out there that we partner with in the neonatal and neurology space. And there's no shortage of work, again, to be done for this, but there's some really amazing people doing it that we get to work with. And it's really just been such a joy these last 4 years in particular, as we've been able to really meet the need of our community head on with increased resourcing and partnerships like this one. Danielle, do you want to scooch back over?
I will just add, this was the original team that started this work of building this HIE registry, but we have grown and we are a lot more people that are really involved and important in these pieces. I mentioned Eric and Joyce earlier. Gina Abraham is a new part of the puzzle and has already really hit the ground running. Monica Lemon is so important in thinking about some of the questions that we want to ask in the long term, especially linking the clinical and the caregiver reported data sets. Rika Messer is my new colleague here at the University of Colorado, and helps with a lot of the EPIC, electronic medical record pieces. We have Seth and Renee are both neuropsychologists who are helping us think about how we're going to capture meaningful data from caregivers, and other neonatology colleagues who've been super helpful also with the piece that Eric has been leading. So I just wanted to end by saying, obviously, the center here are CPRN and Hope for HIE, this wonderful partnership with some additional support from the Newborn Brain Society. PERF provided the pilot funding for us, and the first 2 sites where this pilot registry will start are Children's Hospital Colorado, that's where I am, and St. Louis Children's Hospital at Washington University in St. Louis, which is where Zach Vasulis, the other person I showed on the slide, is. So those are, we will start at these 2 sites, but as we make progress, as we chug along on this work, we plan to expand. We plan to apply for the next stage grant and get additional funding, and then grow this. And the most natural growth would be to other places that are currently CPRN sites. So please get ready to join us, and as we expand, think about how you can both contribute data to the registry and ask questions, get data out of it, and help use it for driving research and quality improvement forward in HIE and CP. And now we're happy to answer any questions. I'm going to stop sharing. Let's
Great,
see.
that was great. Dr. Barber and Betsy, thank you so much. I did answer a question, kind of a detailed question in the Q&A, but why don't we open it to questions? People can either post in the chat or raise your hand and we'll call on you. Lots of comprehensive information there, but I'm sure there are questions. Go ahead, Carol.
Hi, I can't figure out how to type in the chat. I wonder if we
That's
could get
okay.
a copy of that handout, of that visual that you had of the interventions that worked and kind of worked and didn't work. Is there a way we could get a copy of that you showed, Paul?
Yeah, Iona Novak's paper, the stoplight paper.
Yeah, it's actually, I do believe, let me do a quick check and I'll drop it into the chat. I do believe it is one of those papers that that is published and is public access. So, but I'll see if I can, I'll see if I can find it real quick.
Thank you.
I can look too. I think I have it saved on my, in my, it's
Yeah,
a
but I,
good one to come back to over and over again.
yeah,
Paul?
fortunately it is publicly available. So I'm going to just drop it into the chat. And everybody can get it. It's a tremendous body of work. She did one in like 2013 and then updated it in 2020. Okay, so let's see. There are a few questions in the chat.
Oh, I see a question from Amanda. What do you expect your accrual rate to be at your pilot sites? You know, that's a great question. For this grant, we said that we would enroll or collect data from 20 children with HIE at each site, so 40 altogether for this pilot round. And over just 1 year, and then another 20 in the other side of things, from the caregiver side, the AIM2 piece. That's a really small number, and again, this is just a pilot grant, and we are doing a proof of concept. We are trying to show that it's possible, it's feasible. We can collect some data and enroll some people through this process, and through doing this with a small number of people and a small number of data elements, we will learn a lot in the process of where we get stuck, what things go smoothly, which parts don't go smoothly, and where we need extra help. And so hopefully those will be important lessons learned for when we're ready for the next stage and growing and spreading to other sites.
Well, let me add on to that. So we also have this early detection care pathway work that's going on at 3 of our sites at UVA, Seattle Children's University of Washington, and WashU again. And that's going to also lay some groundwork because a diagnosis of HIE is a trigger to go into that care pathway. And so what is part of what defines what we do is we work at the clinical sites and we use the way in which data is captured in the EMR, in the electronic medical record, and then figure out a way to share it so that it can be used across all of the sites and we can collect apples at all places. It is a challenge that we fortunately have Dr. Peoples helping us with, but that's how we'll be able to spread more quickly to more sites. Let's see, sorry if I missed this. Is there going to be
There's a question that maybe Betsy, would you like to address? Jim Dobbins says there's one known therapy for HIE, and that's therapeutic hypothermia, but it's only helpful if given within the first 6 hours. That is true, Jim. What are the main things that are being done as therapeutic protocols through infancy and then beyond? Seems like primarily massage-oriented therapies, including something like the Gillespie method. Can you comment on these?
There's a lot of different research that's going on for interventions outside of the neonatal period as well. So, I think there's a lot of crossover here, obviously, with CPRN, looking at what interventions cross over in that CP space. And obviously, early intervention therapies are kind of the standard, protocol for PT/OT speech for a lot of our kids outside, right out of the NICU as well that they qualify for, but there are also many other types of therapeutics in development, some that are looking at, 3 months outside of the NICU, 6 months, outside of the NICU, things like that. And so those vary. And one of the really exciting things I think about being in this role is I'm able to meet with a lot of these people that have something in the preclinical pipeline, and learn about where they are in that, keep in touch with them. And, you know, we're really excited currently. Well, they're both neonatal focused. There's 2 trials currently enrolling, one for a novel therapeutic. That's a phase 2 trial for NICU babies in conjunction with cooling. But that was not even like a possibility before. I think for many times people were not sure that these things would be continuing forward. And there's just so many more than, I mean, I currently know of 25 different, you know, people working groups that are working on something for HIE that's cooking along, many readying for clinical trials. And when we look at the diagnoses, specific things outside of that HIE can lead to, HIE acquired dystonia acts differently than other dystonias. HIE acquired epilepsy sometimes, like Danielle mentioned, epilepsy onset later into childhood. There's a researcher that has looked at a specific impacted genetic pathway that she's developing a specific anti-seizure medication that could target, you know, and be more effective for our cohort of kids that have that. So a little bit more, you know, with that, hopefully that's helpful. That's just from my non-clinician perspective, but just knowing that I talk to a lot of people in that, you know, out there.
But I will say that one of our motivations for doing, you know, a registry at the NICU level is we were being asked by researchers that were trying to test early interventions for CP, and they asked us, could we, you know, help them recruit? And we're like, oh, well, we don't get our kids until they're 2.
Mm-hmm.
And they're like, well, you know, now that the diagnosis is moving down to, you know, 4 to 12 months, like we want to be able to enroll those kids and have the most positive impact on them. So that's definitely part of this investment, is to get us sort of going in that direction. I want to be aware of the fact that we're at the top of the hour. You know, as long as my internet connection is working, I've got a little more time, but I also want to be respectful of Betsy on the on Eastern time and whatnot. So Betsy, Danny, if you guys have more time, we can see if there are any more questions, but it looks like we're kind of getting through things. Yeah, there's another question there that I can answer in the chat. So,
oh, sorry, go ahead.
Questions.
Go ahead.
I'm
I was
glad.
gonna say, I answered one of someone that asked, like, you know, very eager to participate in surveys. And if you're in the Hope for HI community, you may know that we have traditionally disseminated a lot of these surveys working with researchers like Alexa Craig, like other people, where they're like these red cap, you know, like protected surveys. And we share those into our community through social media, website, email. Putting this into practice when we have it up and running will be a much smoother process. I mean, we'll probably still blast out that these things are available to participate in and encourage people to sign up for the My HIE side of things, but it should be a much smoother process for people to understand. And the goal then, like CPRN, and Paul can talk to this a little bit. I had signed Max up for my CP, you know, his profile, my questions that are the questions I answered about his CP, I can get specific surveys to that. So instead of like doing this broad net, if we have specific research questions, we can put those out in the space as well, which is really helpful.
Great. Dr. Barber, so you gave the nod so you could answer more questions. Betsy, you're okay. I want to answer this question, but I also want to make sure people feel free, they can go. So there was a question about, is the CP registry related to the Canadian CP registry or totally separate? It is totally separate. We looked at all of the registries and we've talked to people, but you know, we had a sort of a very different strategy that we were trying to approach, and so it's a very, very different registry. Still trying to get the Canadians to join our registry. Should someone register on both? Our registry does not exist in Canada, so that's not really an issue. We are trying to get Sick Kids Holland Bloorview to start, and we would say yes if we were, if you were being seen at those sites, that would make sense. You can certainly join MyCP and do our community registry studies from anywhere. We do ask what country you're from, and And that's great. There are great opportunities to participate in research there. Dr. Barber published off of the registry doing a sensory survey to the community. And so it's a great platform for being able to contribute your data in a way that can move the field forward. Okay. Any other questions?
There's one that I see that's like a two-part question. And someone's saying hello to Dr. Barber. So Danielle has a big fan club in the HIE community, as she should. So are there any ways that you all could use any kind of volunteering primarily from parents? We will absolutely be activating people as we move through this. We're in that early stage of, of planning this out. And the question was, if the grant is for neonatal HIE, will you be researching, say, 4-year-olds who are diagnosed as neonatal HIE or starting in the NICU? It will be anyone that was diagnosed, in the NICU, experienced neonatal HIE for this concept, and then we're planning to open that up again. So, when you talk about acquired, that's a checkbox of that side of before you get to any of the consenting into studies, that we can collect that demographic information. And then if there is a survey that is for pediatric acquired brain injury, then that can go directly to that cohort, or it can go directly to the neonatal HIE, or, who knows down the road if we're able to really go with the causation of HIE and target those folks as well. So the possibilities moving outside of this initial starter grant, there's a lot of exciting promise with what we could do with it down the road.
Great. Anything else? Let's see. Is there a way we could find out someone with CP had HIE? My daughter is 20 years old.
I would say talk to your neurologist. Talk to your daughter's neurologist, and you can always review the history, whatever information you had. At this point, probably reviewing the story is the best place to start.
Great. All righty. Let's see. Thank you. Okay. I think we're all into the thank you. So Dr. Barber, Betsy, this has been a great partnership. I look forward to seeing where it goes. Thank you so much. Everybody, sorry about my internet connection. We have a hurricane headed into Seattle. I'm actually flickering in the background, and I'm actually talking through my phone. That's why the green circle is around my logo and not around my face. So I'm glad we made it through. I'm going to re-record my portions for the recording for the people that will follow up afterwards. Thank you all for your time. Have a good evening.
Thank you. Bye-bye.
Thank you for joining.